Hi, my name is Stephen Alsop, and I'll be bringing you the high-yield facts of epidemiology and biostats. Before we begin, I want to suggest that you first use these lectures to grasp the key concepts and save memorizing equations for later when you're closer to your test date. The equations are high-yield facts that are best memorized close to test day. You will most certainly get a handful of these plug-and-chug questions, and you will need to use the right equation in the right situation. Step 1 loves nothing more than to put answer choices down that reflect the right answers but to the wrong question. This lecture will be in 5 parts. We will begin with reviewing types of studies, then move on to describing diagnostic tests, risk quantification, types of bias, and lastly, basic statistics. Let's get started. Common study designs tend to be highly board testable. The boards will often describe a study and then ask, what type of study was performed? The answers will look something like this, offering several different study types as answers. So let's go through each of them. A cross-sectional study is purely observational, and it asks what is happening at this exact point in time. Because it takes place in the present time, it collects data from a group of people to assess the frequency of disease and the related risk factors at a particular point in time. It is a snapshot study design. In other words, it gathers data about exposures and outcomes simultaneously. While it can show risk factor association with disease, it does not establish causality. The characteristic measure for cross-sectional studies is disease prevalence. Now, do you remember what prevalence means? Prevalence is defined as the proportion of people in a population with a disease at any given time. The equation says the number of people in a population with a disease over the number of people that were at risk for getting that disease. An example of a cross-sectional study would be looking at smokers versus non-smokers and their frequency of peripheral vascular disease. Here, you're collecting data in the present moment to assess the frequency of peripheral vascular disease within a group of smokers versus a group of non-smokers. Okay, so what is the major weakness of this type of study? So we've mentioned this before, right? While it can show correlation, it doesn't prove causation. Why is that? Let's say we're looking at a particular risk factor and its association with a particular disease. Now, one might rush to conclude that this risk factor in fact causes this disease, when in fact there could be some other risk factor that we're either unaware of or aren't measuring that causes both that risk factor and the disease. So these two things are correlated, but one does not cause the other. A case control study asks what happened. Because it is observational and retrospective, it looks into the past and compares a group of people with disease to a group of people without disease. The cases are the subjects with disease, while the controls are the subjects without disease. And in a case control study, you are analyzing previous exposure. The typical metric for case control studies is the odds ratio, which in this context is defined as the ratio of the odds of exposure in the case group to the odds of exposure in the control group. But how do we define the odds of an event? So the odds equal the probability of an event happening over the probability of that event not happening. Okay, so let's define P1 as the probability of exposure in the context of the disease. And let's define P2 as the probability of exposure in the context of no disease. Now, if we do that, putting everything together, we define the exposure odds ratio as P1 over 1 minus P1 over P2 1 minus P2. So this together would be the odds ratio. So let's try to make this more concrete by using a specific example. Here we have an example of a case control study where we're looking at exposure to asbestos, which is a material found at construction sites and shipyards, and the development of mesothelioma. Here, you're looking into the past and comparing cases with the disease to controls without the disease, and analyzing their previous exposure to asbestos to see if cases with cancer had higher exposure rates. So, Suppose the study finds that the probability of exposure to asbestos in patients with cancer is 0.75, while the probability of exposure to asbestos in disease-free patients is 0.25. Now, how do we set up our odds ratio equation for this? Well, we would do 0.75 over 1 minus 0.75 over 0.25, 1 minus 0.25. Plugging the numbers into our odds ratio equation, we get an odds ratio of 9. So a patient who has exposure to asbestos was 9 times more likely to develop mesothelioma. Next up is the cohort study. A cohort study can be prospective, in which case it asks who will develop disease, or it can be retrospective, in which case it asks who had exposure. It compares a group with a given risk factor to a group without the risk factor to assess whether or not that risk factor increases the likelihood of disease. The cohort is the group with the given risk factor, and in a prospective study, you follow the cohort into the future to see if they get the disease of interest. The characteristic measure for cohort studies is relative risk. This is defined as the ratio of the probability of the event occurring in the exposed group versus a non-exposed group. And what that looks like is basically just P1 over P2. In this case, P1 is the probability of having the disease if exposed, while P2 is probability of having the disease if you were unexposed. This study answers the question, how much more likely is the patient to develop mesothelioma, to use our previous example, if they work at a construction site with asbestos? A different example of a cohort study is the famous Framingham Heart Study. One thing this cohort study examines is uncontrolled hypercholesteremia and future risk of myocardial infarction. Here you are looking into the future to see if groups with uncontrolled high cholesterol have a higher likelihood in the future of developing a myocardial infarction. So suppose that P1, or the risk of developing the disease if you have high cholesterol, using our same numbers before, is 0.75, and P2, which is your risk of developing an MI if you don't have high cholesterol, is 0.25. What is the relative risk? Well, this equation is actually a lot simpler than the odds ratio equation, because all we're going to do is put 0.75 over 0.25, and that equals 3. Here's another way to compare case control studies and cohort studies. This point is the present. In case control studies, there are two groups at the present time, one group that has the disease and the other that doesn't. The study looks to the past to find out were they exposed. So what would a cohort study timeline look like? Well, again, if this is the present day, then you have two groups. All the patients are healthy at this point, but one group has an exposure and the other group doesn't. The study looks to the future to ask who will actually develop the disease. The last two types of studies are twin concordance studies and adoption studies. Twin concordance studies compare the frequency with which both monozygotic twins and both dizygotic twins develop a disease. This measures the heritability of a disease. Specifically, the more concordance the disease shows for monozygote twins relative to dizygote twins, the greater the heritability of the disease. Adoption studies compare siblings raised by biological versus adoptive parents to separate heritability from the influence of environmental factors on disease. This is looking at that characteristic nature versus nurture when it comes to complex diseases. Okay, so here's a summary slide of the types of trials to help you memorize the main differences. You can refer to this. There's also information in your book that will help you to solidify all this information. But we've covered sort of the main high yield points that you need to be able to do well on the exam. So let's do a sample boards type question together to see if you understand the differences between these different study designs. A study was conducted to determine the cardiotoxicity of azithromycin, a macrolide antibiotic that you should have learned about in microbiome. One group of patients taking azithromycin is compared with a matched group of patients not taking any antibiotics and it was shown that the azithromycin group had an increased risk of cardiovascular death. What type of study design is this? So the answer here is B, a cohort study, and it is prospective. We know that it is a cohort study because the question tells us that we are comparing two similar matched groups. Additionally, one group of patients experienced an exposure to azithromycin and are now being observed for development of a disease. This is prospective because both groups are being monitored for future events. Now for the bonus point, what kind of information can be extracted from this type of study? That's right, the relative risk of azithromycin exposure and cardiovascular death. Our next topic is the clinical trial. Clinical trials are experimental studies involving humans, and they compare the therapeutic benefits of one treatment versus another treatment, or of a treatment versus some placebo. So, what are the characteristics of the highest quality clinical trials? Well, they should be randomized, controlled, at least double-blinded, and by that I mean neither the patient nor the investigator know whether the patient is in the treatment or the control group. So how can a study be blinded? Well, when the study is single-blinded, the patient doesn't know if the pill they got was the real drug or the placebo. However, the doctor and the researcher both know what the pill contains. In a double-blinded study, neither the patient nor the doctor knows if the patient got the placebo or the real drug. Lastly, in a triple-blinded study, no one knows, not even the researchers analyzing the data know which pill the patient got until after they've analyzed all of the data. More blinding results in less bias of patients, doctors, and researchers. So there are 4 types of clinical trials, also known as phases, and they go from phase 1 through phase 4, each one progressing from one to the next. However, there are also new phase 0 trials that are called first-in-human or microdosing studies. This is where 10 to 15 healthy volunteers receive single subtherapeutic doses of the study drug to look at pharmacodynamics and kinetics and to confirm in vitro and animal data. Now, because study participants are getting lower than normal drug doses, you don't get any information on safety or efficacy. In contrast, classic phase 1 clinical trials study a new drug in 10 to 20 participants, usually healthy volunteers, and they assess the safety, toxicity, and pharmacokinetics and pharmacodynamics of that treatment. Phase 2 clinical trials study a small number of patients, usually on the order of hundreds, with the disease of interest, and then assess treatment efficacy, what is the optimal dosing, and what are the adverse effects. Phase 3 clinical trials study a larger number of patients, often in the thousands, depending on the disease prevalence. Patients are randomly assigned to either the treatment under investigation, to the best available treatment, or a placebo if there is no approved treatment. These studies compare the new treatment to the current standard of care. It is at this point that the treatment may or may not receive FDA approval. And finally, phase 4 clinical trials are designed as post-marketing surveillance trials of patients after drug approval, in an effort to detect rare or long-term adverse effects. Take a look at the simplified chart of the 4 phases of clinical trials to help you remember. Phase 1 asks, is it safe? Phase 2 asks, does it work? Phase 3 asks, is it good or better than the current thing that we have? And then phase 4 asks, can it stay? Okay, now it's time for a flash quiz. And the question asks, what does it mean if a trial is single-blinded? Well, as we discussed, in a single-blinded study, only the patient is unaware of the treatment being administered. However, the doctors and the researchers know whether the patient is receiving the standard of care or a placebo or the experimental treatment.